This will be a joint talk between me, I'm a radiation oncologist at the Brigham and Women's, Dana-Farber, and Lauren Conway is one of our chief therapists. So this is how our talk fits into the grand scheme of how sbrt can be implemented for the benefits of patients and their treatments. And just to give an overview of what we'll be talking about today, we'll start off talking about background and clinical rationale, then take a deeper dive into a case study of the practical implementation of sbrt for non-spine bone, sbrt, and then end with discussing the clinical impacts of a tattoo-less workflow in our clinic. So this is a theme I think has already been touched on by some of our prior speakers, and the reality is that sbrt treatment has dramatically increased over the past several years. The plot on the left reflects the sbrt volume per year at our own institution, beginning in 2009, from about 10 patients to, on this graph most recently plotted in 2021, where we had more than 800 patients. On the right side, we take a more granular look at which specific disease sites are being treated. And similarly, you can see in parallel with the dramatic growth of lung sbrt, our own institution has also had growth specifically in spine and non-spine bone, among other disease sites. So this sort of sets the framework for why there is such a strong clinical rationale in exploring how we can make these types of treatments better, faster, and more efficient for patients. There's an expanding menu of indications for sbrt, including the role of sbrt in treating oligometastatic disease with ablative intent. As patients are living longer, as systemic treatments improve, we are having to more frequently do reirradiation, where organ sparing becomes even more important. Potentially, sbrt is superior than conventional radiation for addressing radio-resistant histologies, and there's also some data suggesting that specifically for bone metastases, there may be other benefits as far as pain control. Incorporating sbrt for treatment setup or treatment delivery may reduce treatment time and improve the fidelity of treatment delivery. And as mentioned, a faster and more efficient treatment ultimately improves the patient experience and also expands operational capacity. And being able to treat patients more quickly certainly has direct impacts on their clinical outcomes. So to focus specifically on non-spine bone sbrt, there are some unique clinical considerations. First of all, maintaining the accurate position of the entire joint is critical for non-spine bone sbrt, and this is due to the highly conformal nature of VMAT plans. Up until 2019, pre and mid KV or cone beam imaging was our institutional standard, given the ability to visualize bone so clearly, and also the tighter margins and tolerances that were used at our institution for this type of treatment, which is 2 millimeters and 2 degrees. However, there is a trade-off of using onboard imaging to ensure setup accuracy and also extending the time that's needed to deliver treatment. The longer the patient is on a table, the more likely they are to move. And so you could be losing all the potential gains you're getting from using tighter margins. So we had a number of clinical questions within our group and institution as far as how we could best incorporate sbrt into our clinical workflows. The first question was, how can sbrt minimize the time or imaging needed for initial setup of non-spine bone sbrt patients? Secondly, given that we've often viewed KV and cone beam imaging as the gold standard for visualizing bone, how can sbrt, which is a surface marker, be used as a surrogate for intrafraction motion monitoring, specifically for bone? And then finally, can sbrt replace the need for leveling tattoos for non-spine bone sbrt setup? So this timeline gives a sense of, within our own clinic, the process and events that were involved with how we started with just experimenting with using sbrt for setup in December 2019, to what it took to get our clinic to a or tattoo-less workflow, specifically for this scenario. So in December 2019, we first started piloting how it could be used. In July 2020, we started to use it standardly for all non-spine bone sbrt, in addition to our existing workflows. In January 2021, we removed KV mid-imaging and integrated sbrt, along with target tracking and triggered imaging, as well as safety gating when appropriate, for all non-spine bone, rib, and sternum sbrt cases. And that's something that Lauren is going to speak to in great detail momentarily. In June 2021, we collected the data with the leadership of our physicists and therapists in order to review how comfortable we are clinically, or we were, with transitioning to a new workflow, such that in February 2022, sbrt combined with target tracking and triggered imaging became the workflow for all non-spine bone sbrt treatments. And that is ultimately what allowed us to feel very comfortable a year later with going live with a tattoo-less workflow for all non-spine bone sbrt. So although this pathway looks very linear, there were a lot of challenges that we overcame in considering the experience that affected patients from end to end, including transitioning from a very rigid immobilization to being more comfortable with an open immobilization, and how to prove that Vision RT was at least as good, if not better, than what we were doing before. So with that introduction, I'm going to turn it over to Lauren Conway.
Thank you, Mayan. So I have the pleasure of discussing our non-spine bone tattoo-less workflow. So as Mayan mentioned, we initially started our sbRTs with very rigid setups, very covered with all of our immobilization, and it was a learning curve to have us feel more comfortable with having our patients more exposed and to have less immobilization. So this is an example of a standard iliac, acetabulum, femur type setup. We set up the patient per our SIM instructions, and something that we do in our clinic that helps ensure that we're set up for success when using the system is we put marks on our vac lock bags, and they align with index points on our sbRT boards. We start off with making sure that those are aligned, and then we move our couch to the coordinates that are given to us from our planning team, and we turn on the Align RT system, and we position the patient and shift the table to so the deltas are in the green. And so this is what this looks like before exiting the room. A few helpful hints that we found along the way were creating protocols with specific deltas. So for our non-spine bones, all of these, when we import the plans, it has a 2 millimeter, 2 degree tolerance that we're already importing based on the protocol. For other sites like our lungs, and we do 3 millimeter, 1 degree, and for our spines, we have 1 and 1. So those are already imported so that when we pull up the plan and we're setting up the patient, that we're already setting them up within those tolerances. Another helpful hint is to always make sure that you're adjusting your ROI on the fly if you need to. That takes us to some of our experiences with ROIs that worked versus, it was over the years that we've figured out that, taking gating captures, removing the abdomen on pelvic patients, we're changing the supinemph or the pitch of the patient. If we drew the ROI too far down the femur for our pelvis patients, we were finding pitch issues. So, if you're in the hip, your hip is obviously can move separate of your pelvis can move separate of your leg, right? So, if we draw it too far down the leg, then the pitch of the leg position can change with your full positioning and your pitch position. So it's really important that we were, making our ROIs reflect the area that we were treating. For humeruses and shoulders, making sure your ROI doesn't come too far back so that the cameras can't see. That was a big learning curve for us, making sure that we're stopping at a mid-coronal plane for these cases so that the roll and rotation could be accurate, but that we weren't setting our cameras up for not success, right? So once we step out of the room, we take KV images, orthogonal pairs, we take a cone beam, and so for our institution, 2 millimeter, 2 degree is our tolerance. It needs to be at or under that in order to treat. Our physicians approve those cone beams. And so our second RTT, not driving the machine, takes a reference capture. And so for the first fraction, we have them take it for this and future sessions. And for subsequent fractions, we have them take it for this session only. We have them take it for this session only to ensure our deltas are always zeroed. So that if our patient is moving, that they're in the red, they're actually that have moved 2 millimeters. And so this is a typical side to side. So the driver's looking at the monitor with the KV triggered imaging tracking structures, which I will go into more detail in a second. And then our second RTT is monitoring align RT deltas and the postural video. So we have to credit Mike Tolomer. He did a talk for us and mentioned how they used triggered imaging with structured tracking. And our physicist, Scott Friesen, who took that and ran with it. And so we use variance true beams to treat our stereotactic cases. And so we take images during the VMAT plan. As seen previously, so we have you can go back to the previous slide here and show you. So that right there is the target, and then the tracking structure is the larger green portion. We have the first line closest to the iliac crest is at the bone, at the rigid bone structure, and then the further line out is that 2 millimeter tolerance. So if we see the bone outside of that 2 millimeter tolerance, we would turn off the beam. So this is a visual monitoring with the tracking structure. This is another example of this. So this was a rib case. You can see the rib PTV contoured out in the red, and the tracking structures were contoured with the ribs superior, inferior, and the affected rib. And then this is what the therapists are seeing in real time on the machine. And so the contour filter is on there, so it's a little bit grainy to see, but when you're up close to it, you can tell that the ribs are within the contours. And we use, for our rib and sternum cases, the RGSC variant block that goes on, so it also is another safety gated component because we don't have MMI turned on for that machine. So just to recap the workflow, we set up the patient in the room, we come out, we take the KV, we shift the couch, we take a cone beam. Once the cone beam is within our desired tolerances, the MD approves, we shift the couch, we reference capture and monitor the deltas, and then we start treatment on the arcs with the sbrt and triggered imaging combination. Currently, we are doing this workflow for non-spine bones, lungs, and our lymph node cases, and our future sites are spine and GIGU. Mayan's going to take us through clinical implications.
I just have to give a lot of credit to Lauren and our therapists and physicists for also making this very proceduralized, making it very clear what the role of the driving and co-pilot therapists were as far as monitoring the patient and monitoring the surface. But ultimately, you know, at the end of the day, we were very interested in understanding whether or not this new workflow, how is it affecting our clinical outcomes or directly for the patient, and also when it comes to treatment time. So with this graph, we actually reviewed all patients treated with non-spine bone sbrt analyzed by quarter from about a year prior to starting this to about a year afterwards. And so in this particular plot, the focus is on rib sbrt because that was one of the settings where there was a very clear benefit. Skip the slide. So the most, I guess, important thing was there was a reduction in the total treatment time for rib sbrt. So this type of plot is called a statistical process control plot. It's a way of measuring whether a process improvement initiative is actually making a meaningful impact that potentially could be attributed to the intervention. And so on the left side of the graph, this is how we started off in about a year before we started implementing this pilot. From the time that OSMS was introduced for non-spine bone, which is the first red arrow, there was a significant reduction in the total treatment time, specifically for rib sbrt. And overall, that continued and was statistically significant. One could also argue that overall, the process became more controlled. And so that was a very quantitative measure that the intervention, although we thought was better, was clearly making a difference when it came to patient treatments. Another advantage certainly would be the reduction in radiation exposure. So now with this new workflow, we no longer had to do mid-cone beam imaging, and that was also something that was very significant and controlled specifically for patients treated with rib sbrt. And looking then at other non-spine bone disease sites, so acetabulum and ilium, overall it did appear that there were also significant reductions with, again, that change of a line of points basically below the green line, about 2 or 3 standard deviations below, which would be considered significant. And this specifically was related to treatment setup. Not necessarily the total treatment time, and there could be other variables that would have impacted that we need to explore further. So in conclusion, we successfully transitioned to a tattoo-less workflow for non-spine bone SBRT, utilizing SGRT for setup and mid-imaging, and then a combination of SGRT and triggered imaging for real-time interfraction motion monitoring, which actually exceeded what we could do before in giving us a mechanism to actually monitor the patient throughout the actual treatment. Implementation of this workflow was associated with significant reductions in treatment time and cone beam imaging required for rib SBRT and reduced treatment times for acetabular and ilium SBRT. Ultimately, when it comes to the purpose of doing SBRT, specifically for non-spine bone, a higher fidelity treatment should lead to improved clinical outcomes, reduced toxicity, and ultimately, I think no one could argue against the fact that there are many improvements for the patient experience related to faster treatment times, reduced radiation exposure, which is unnecessary, and also omitting the need for permanent tattoos for patients, which is also a permanent reminder of their treatment. So with any project, there's a whole village of people involved, and we wanted to give extra thanks, to all of the people who were involved with this work over the past few years. Many of our medical physicists, our sim and treatment therapists, our fellow bone SBRT physicians. I'd also like to specifically thank Andrew Zhu, who's a very talented medical student who's been helping to quantify very systematically all of this data. Joseph Killeran, who helped us to extract it from 2019 to the present. We have incredible support in our departmental leadership. Todd Vivenzio, as well as Michelle Physics, are here today as well. And I also wanted to thank the MGB Clinical Process Improvement Program, through which many of our department has gone through, and I think that helped us to think about how to quantify the impact of this change in a more systematic way. So with that, thank you so much for all your attention.